Get ready, have seats, we start.
Want me to see the mouse? And then when you go to the case room, we're gonna see if I can hear you, okay? In here. Should be able to hear you.
Hey, Helen. Helen, can you go to the room and say something? Why does it say internal because we can hear this computer. Perfect. Okay. Great. You can yell at her, tell her she's good.
Okay, we'll start. Okay, thank you very much, Dr. Bailey, for this is the first time Dr. Bailey joins the course for this year, and after the COVID, we are back to do things live. So we will do the ACLS part as lecture and part as actual cases that Dr. Bailey will run with you, which will give you more information. Thank you.
Hi guys, I'm Lacey. I'm one of the, or the only, I should say, Med Ed and Sim Fellow in the emergency department. And then I also work in the ER. So I've met some of you and seen some of you wandering about the ER. So I apologize in advance for all the patients we've met. So ACLS, we're going to talk a little bit about first in the classroom, and then we're actually going to get hands-on. This session is best if you guys participate. I can sit in awkward silence for a very long time. And so the sooner you guys answer and participate, the faster we'll get through this and the sooner you'll get to leave for the afternoon, because I think I'm the last one. So participation is highly encouraged. All right, so we're going to start with just a reflection on kind of what you guys have experienced this year. So we're talking about codes and in-hospital codes. So I assume by this point in the year, you guys have at least seen one, probably not run it, but at least been to one or responded to a code on the floor. So what has gone poorly when you've showed up to these codes?
Empty code cards.
Empty code cards?
Yeah, no empty code cards.
Okay.
Two-way communication.
Okay. Not great communication. Not effective compressions. Or no compressions. Big problems. Okay. No IV access. Okay. No roles assignments. Okay. What has gone well with codes that you have seen? Nothing. Not a single thing has gone well. Everyone has just died and it's been a cluster.
I think rhythm assessment sometimes.
Okay, rhythm assessment has gone well. Okay. So out of all those things, what are kind of the common themes that tie all those things together that has made something go poorly? I heard it. Communication, teamwork, leadership. It has nothing to do with an ACLS algorithm or knowing when to give epi, right? It is all about communication and teamwork. So that's what we're going to focus on today. All right, so we're just going to kind of review some of the characteristics of what good teamwork is, and then we're going to practice that together, okay? So clearly defined roles, you guys mentioned this, right? So what are the roles that you want when you go into a code on the floor? Someone doing compressions, a timer, medications, airway, a leader, access, what? Leader, yeah. Good, so that's good. I would say in addition, there's gonna be a million hands, right? At a certain point in time, you get to the point where you've like saturated the room and there's too many people. So compressions is good, and then someone to switch out compressions, right? Because you don't know how long you're gonna be doing this and it is exhausting to do compressions. All right, but otherwise, team leader, IV access, medication, airway, compressions, Those are kind of your core people, but a timer is like one of the most important people. I see this all the time. We do this with our ER residents regularly. And if you don't have a timer, everybody's standing there looking at each other saying, when is our next pulse check? So assign that role early. It's one that can be forgotten, and it seems like it's not as important as some of the other roles. I mean, sure, chest compressions are important, but it is also good to know when you're going to stop and check for a pulse again. All right. So shared mental models. This is really easy when it comes to ACLS, right? Everyone is ACL certified. We all have the same model. The question is, do you know the model? So do you guys have something that you keep in your pocket or on your phone, or do you have it memorized? What do you guys use for codes? Nothing?
Kind of ACLS card.
Yep, so there's usually a card, and it's usually on your code card, right? There are apps that you can download. The one that I like is called MediCode. It has a little blue background with a heart. You guys probably can't see this, but it's like a white heart on a blue background called MediCode. It's super fast to get to all of the algorithms, and it has this feature where you can practice. So if you don't feel comfortable with it, it is free. You can download it on your phone, and you can practice the algorithms, and you can practice like resuscitations, okay? So have something that you guys know you're gonna be able to find quickly in the chaos of a code if you're gonna be the team leader in the room, if you don't feel confident with your mental model, okay? It's okay to not feel confident with it, and it is really okay to offload some of that mental tasking onto something else like a code card or an app in your phone. So if you guys want, I'll show you that later, but if you don't have it, find something that you like. The other thing that they have are the American Heart Association sells like these code books for all of ACLS. I have it in my bag. I just left it on the other side of the room, but they have all of the ACLS algorithms. I like it because we see PEDS too, and it has NRP and PALS in it. Thank God you guys don't have to do that, but it will have all your ACLS stuff. So if there's something you like, you can download the app or buy the code card, or just rely on what's on your code cards in the room. All right, dependability. So this means, in the sense of running an ACLS code on the floor, it means that when you give someone a task, you know that they can perform that task, right? And you know that someone else is going to be able to, like, if you say, I want you to do IV, that they're going to be able to get that IV, right? So part of this is that you know what other people are capable of. I realize that on the floor, this can be really difficult because you guys might not know the nurses that you're working with. We always have nurse turnover. You never know who's going to show up. It's kind of just a mess of whoever runs into the room at the right time. But know that it's something that's important, and if you don't feel like they're getting the job done, don't be afraid to tell them, like, I want you to switch out or have someone else perform that task. Mutual performance monitoring is kind of the other half of the coin with dependability, and this is the part of the code that you can tell someone else that they're not doing their job correctly, but in a constructive way. So this is when you're seeing someone do chest compressions and they're too slow. Be like, hey, you're doing a good job with depth, but speed it up. And so this is where you should feel, no matter what your role is in the room, that you should be able to correct or help someone perform their role better in some way. And so this helps teams to perform at their highest level, right? Closed loop communication, I feel like, needs no explanation because everyone knows what it is and no one does it in real life, right? So this is something that I really want you guys to practice today when we're in the rooms doing these simulations, because it really does help. As the team leader, it's your job to make sure everything is getting done. And if you tell someone, give epi, and you don't hear that it's given back, or that they don't respond with like 1 milligram of epi given, you need to be able to be like, hey, did we give that epi? And they should have already told you. And if they haven't, you should assume it hasn't been done. So this is important, no matter who you are on the team, to do closed loop communication. And then team leadership. So this is really the role that you guys are going to be stepping into in the next year or 2 years and the rest of your career, right? You're going to be the person that shows up to the room, and you're going to ultimately be tasked with leading the team with the resuscitation. And so your leadership skills are important, and we kind of touched on some of that already, right? Closed loop communication, monitoring other people's performance, assigning roles early and being very clear about what those roles are. And then the other thing is like being able to just step up into that role. It can be really hard to walk into a room of a bunch of people that are already there and feel like I'm in charge now. And so it's getting comfortable with taking on that role in the next year, so that you can do that. Because when you show up, you really should be in that role. So don't shy away from it. Yes, ma'am.
I think something really important that I have noticed in the current here though is when the team leader is also open to receiving feedback, because we all have had the ECLS, when we're in these situations where we have high adrenaline, sometimes two brains are better than one, and you forget some of the algorithm. And so listening to somebody else and leaving your video on the door and being able to say, you're right, we need to do that, I think is a big thing that needs to be worked on in this hospital.
That's a really good point about team leadership. So for the Zoom recording, I'm just going to repeat what you said. But basically what she's saying is that whenever you're the team leader, not only do you have to step up in the role, but you also have to be open to taking feedback within the role and listening to what other people have to say if they have suggestions. That is one of the other things that I think we don't, I don't know if I see it. I've never seen floor code here, right? So I don't know what you guys do. But in the ER, we actually do this a lot, and we'll ask out loud, like, does anybody have any other suggestions? Does anybody have any other thoughts? And I think that's a really good kind of habit to get into as you're leading these codes. All right. So real quick review, clearly defined roles, shared mental models, dependability, mutual performance monitoring, closed loop communication, and then good team leadership. All right. So that is what we're going to talk about in terms of that. So when we go in and do these simulations, what's going to happen is that we're going to break up into groups. So I have 4 different cases, so like 6 to a group, it looks like. So each of the cases is different. During the case simulation, there's going to be 6 people in the room doing the simulation, and everybody else is going to watch it in this room. Okay? So everybody is going to see all of the cases. Obviously, I'm not going to be in here to pay attention to if you're paying attention, but I'm going to come back in the room and I'm going to ask questions about it. It would be helpful if you see all of the cases because they are all different pathologies, and it will be good for you guys to see from an outside standpoint how it feels to do the simulation or to watch it. You can pick up a lot of different things in terms of learning how to do better by watching other people do well. All right, so I don't know if we just want to do like each row is a team. I think that's probably the easiest. So we'll have, group 1, group 2, group 3, group 4. And then Dr. Hoover, you guys probably mostly know her. She's one of our second years. She's here to help me today. So she's going to be in the simulation with me, and she's going to help us kind of be like a nurse. Have you guys done simulation here before? Yes. Okay. So the simulation mannequin that we're doing is a low fidelity, which means that it basically does not have all the bells and whistles of the high fidelity mannequin. It does allow you to do chest compressions. That's about it, okay? And that's it, all we really need it to do, right? So in the room, it's going to be, okay, so you guys have seen the sim room. This is what it looks like. All right, so we have the mannequin here. You guys can do chest compressions, you can do BVM, you can ask for things to be done, and then you can ask me for things about the mannequin and about vital signs and everything. We have this monitor right here. So you guys have seen these, they're like the Zoll defibrillators. To get your monitor, you just turn it to monitor. To get it to defib, you turn it to defib. If you need that, I don't know. Maybe you will, maybe you won't. So that's where you're going to see your monitor with your heart rate and your rhythm. Everything else you're going to have to ask me for, all right? Along with pulses, so you won't feel pulses no matter what. So you can ask me if the mannequin has a pulse. And then everything else like history and stuff, you'll get from just asking the patient and you'll get a response from me, okay? This patient is an inpatient in the hospital. They have a hospital gown on. They have one IV for access that you guys can see if it works, etc. And then you can order any medications that you want. I would encourage you, if you have an app on your phone, have it pulled up so that you get used to using it in the room. We are not going to assign roles before we get in the room. So I would encourage you to start practicing your team communication with some such practice of assigning roles early. But you guys can do whatever you want. It's your simulation. What questions do you guys have for me about what we're going to do? Nothing? All right. After we do the case, we're all going to come back to the classroom and we're going to debrief in here as a group. Okay, so debrief is an important part of simulation where we go through what happened, what questions we have, and reflect on what we did, because honestly, the learning doesn't come from doing it. The learning comes from looking back at what you did and learning from that. All right. All right. Group one, let's go do our simulation. You guys should be able to hear it in the classroom, okay? If you can't, come get us or come get Marquise, all right?
So try to listen to them. And,
Help. All right. Hi, guys. I'm the nurse taking care of Mr. Johnson, and he just gave me a call and told me he wasn't feeling very good all the time.
What's been going on?
Well, I just all of a sudden felt really short of breath.
What is he here in the hospital for?
So he was admitted yesterday because he had influenza. He's had a cough for 3 days, and he just been feeling really weak. So he was working with physical therapy today, and they called us and told us he was really short of breath all of a sudden.
Do you have his current vital signs?
Louder, I think. Let me ask my colleagues if they can get it louder.
Do you have his current vital signs?
Well, we'll have to get him hooked up to the monitor first. So if you guys want, I'll work on getting a blood pressure. So
Sure.
I'll put the blood pressure cuff on and we'll get it hooked up to the monitor. And this is what his monitor is.
Is there anything else you guys? Your heart rate, respiratory rate.
All right, there's your monitor. So his blood pressure right now is 145/93. His respiratory rate is 20. His temperature this morning was 38.5, and he's 92% on room air with a heart rate of 170. Yes, he's talking to you.
Can you talk to me?
He has a history of high blood pressure.
And right now, is he feeling palpitation or sinking heart feeling?
He is feeling like his heart is racing and that he's having some shortness of breath.
No dizziness?
No dizziness.
Do we have idea?
We have one IV working in the right AC. Yep, we can try that. However, I would have someone in the room do that if you can. Okay.
Can we step back on the side roll so fast? Sure.
Okay.
We're expecting something.
To talk louder.
Okay. He's really loud.
Okay. Talk louder. Sure.
Did his heart rate go down?
No, his heart rate did not change a bit when we were. Okay. So if you want, you can get an ECG and it will look like this.
Okay.
so we go.
So take a good look at your monitor.
Mhm.
you want to do 6 of adenosine?
There was no asthma, right? No Mr. Phasma?
No.
But it's no.
Okay, so we gave a dose of adenosine and nothing happened.
You know,
What did you,
It's BJ again, 17, 10.
adenosine 12?
And his blood pressure is still 140.
Yep, right now, so 140. Okay, who's gonna do that? Someone is
I
fine.
can-
to
I
do
can-
it?
I can do it.
Okay.
Yeah. Are the meds over here?
You can just for one.
Okay, I will draw up, how much Zolpidem would you like me to give?
I wanted to give you the 10 milligram, the middle.
Okay, I can do 10 milligrams of metoprolol. Okay, I'm drawing it up and I'm giving it. 10 milligrams given.
Any change?
Oh, I really don't feel very good. I'm trying to feel really sick in my stomach and I'm getting really, really dizzy.
What's the blood pressure?
The blood pressure is 92/54. The heart rate's still 170. Oh, I don't feel good.
If his blood pressure is dropping, we should consider doing a synchronized cardioversion.
If he's still in AFib.
If he's still, but
Yep, ECG is unchanged.
Okay, so then do we want to get all the
Yeah.
materials ready?
Okay. What do you
Hook them
need?
up to the paddles.
Okay, so these are your paddles. They just clip onto his chest. Yep. Yep.
Have her attached and like,
Okay, so when it's like this, we can't change it, but you would just turn it synchronize. Sync on.
Yep.
Okay, and you know to give your.
Gotcha.
Okay, where do you want me to set it to?
100. Say it again, how much you want? 100 drugs, we started
usually,
with, we start 100 and then go.
I'm setting down 100 euros.
$200.
Alrighty, is that okay?
You'll charge that.
Okay,
I'm gonna go ahead and charge.
Are we clear? It's clear.
Delivering check. And check delivered.
How you feeling, sir? Still awake?
I'm still awake. My chest kind of hurts after that shock, but I feel a lot better. My heart isn't racing and I'm not short of breath anymore.
I want to see the blood pressure right now.
The blood pressure now is 120/80.
I want to set, I'm sorry, Caperton to, I want to do cardiology on board.
Okay, we'll call cardiology.
And we'll do, echocardiogram tomorrow.
Sounds great. It sounds like a bunch of inpatient orders. All right, we'll get that stuff set up and we'll give you guys a call if he needs anything else. All right. Thank you for coming so quickly.
Thank you.
All right, you guys can head back to the room and we'll be brief later. This is case 2. It's all right.
So just remember when you go there, talk to.
All right. Team 1, can you, since we couldn't hear very well, can you guys tell everybody what happened with the patient and what interventions you did? Someone, anyone?
Patient was short of breath, he was found to be an AFib with RVR, was originally stable, then became unstable. We synchronized cardioversion. and be safe.
Perfect. All right, so he had shortness of breath. He was in AFib with RVR. They tried adenosine first, and then they tried metoprolol, and then the patient became unstable, and then they did synchronized cardioversion, and it converted him back to normal sinus rhythm. So how do you guys think it went? Anybody, open to all observers and participants.
I like Bill's close loop communication.
He did a good job, yeah. So closed loop communication was good for giving the metoprolol. Did you guys feel like you did a good job with closed loop communication the whole time?
Not necessarily.
Not necessarily.
I think it was just strange, all getting there, getting used to that, just that environment.
Yeah,
We didn't really assign roles.
yeah.
We were definitely open to everyone having their own ideas on that.
Yes, I agree. So I could not tell who the team leader was in the room. So there was no clearly assigned team leader and nobody assigned roles. But I think you guys did a good job of overall communicating as a group. But that is a dangerous thing to get into with ACLS on the floor, right? Because you don't have anybody that's in charge of the room and making decisions. And if there's any sort of like, well, maybe we should give adenosine, maybe we should give metoprolol, there's no clear person that the nurse is looking to give medications, and now you're delaying the patient's care, right? So it's harder than it sounds, right? It's really easy for me to stand up here and list 6 things to good teamwork, but to actually go into a room and this really unfamiliar environment and make that happen is really awkward, right? So you guys are disadvantaged because you're the first group to go in there, and now you guys kind of understand. So when you walk in the room, assign roles first. So what roles did we talk about needing? Timekeeper. Less important with some of the tachydysrhythmias, but good to have, right? Because they can decompensate just like anything can. Okay. A leader, yep. So we want someone to step up and be like, okay, I'm going to be the team leader. When you guys go to a code together, is it like all the teams together in their workroom and a code gets called and you all walk together?
No.
No, it's all like you're scattered about and then you show up at different times.
Well, whoever's patient it is, they go. A lot of people don't go.
Okay, so whoever's patient it is. So it's kind of assumed you're going to be the team leader if they're your patient, is that right? And you're the senior?
But really, I think it really helps for us to really have somebody identify themselves as the leader and then just, well, you do this, you do this. You do this.
Okay, so even if it's assumed that you're the team leader, you think it's important when you show up to assign yourself and tell everyone like, I'm gonna be the team leader. I know our ER residents go up to codes too if we hear them, right? So if they show up to a code, do you guys still lead the ACLS or do our seniors run the?
Depends on who gets first there and who's more comfortable running it. So sometimes the internal medicine resident will be running the code, and then the EM resident shows up, and the internal medicine resident doesn't feel comfortable running the code, and so they will just step down, step back, and let the EM resident run it from then on.
Okay, 2 years from now, I want to check in with my interns and see that you guys are kicking them out of the room. Okay, we need them downstairs. We're busy. All right. Anybody have any other thoughts on this case?
I have some codes.
Yeah.
It's actually they were disadvantaged because we were the first group, but also because the situation is kind of atypical.
Mhm.
It doesn't simulate what happens on the floors or
Okay.
when you are on service. Because most of the time, if patient's tachycardic or dizzy or something like that, the nurse will call the resident who is on that team taking care
Sure.
of that patient,
Okay.
and the resident will go on his own, start
Okay.
managing if they feel that it's like during the day or the night, if they feel like they're not comfortable managing it, they will call the supervising
Sure.
resident, the senior resident,
Okay.
and then people start getting in the room.
Okay.
So there is always someone who was first in the room who's
Mhm.
primarily in charge of the patient.
Okay.
And they are the assumed leader until or unless they step down and let someone else take over.
Okay.
The other thing is that there's usually kind of a hierarchy. So if like
Mhm.
I am the intern of the team and I have a senior resident and I have an attending, so
Yeah.
it's kind of clear that if I'm there, the attending is there, the attending, oh, and the fellow, if I'm in the ICU,
Mhm.
kind of everyone knows who the leader is
Okay.
most of the time, but I cannot imagine a situation where 6 interns walk in the room.
Fair enough, fair enough. Yes, all right. So the point, just for the Zoom recording. So the point you're making is that it's very awkward and it's not really realistic or simulating what an actual environment would be. Because 6 of you aren't going to walk in the room at the same time.
Unless it's a code blue.
Unless it's a code blue. Okay. So in that case, I apologize. I think that this is one of those times where simulation does not necessarily mimic real life, but it is important for you guys to get used to those roles. Did any of you feel like you were the team leader in that room? Do you feel like if you had showed up by yourself, you would have been able to manage that patient and take on a team leadership role and felt comfortable assigning roles to other people? You think so? Okay, do you see the importance of doing it? Good. So I challenge the next 3 groups to fight for team leader. Otherwise, you're going to be assigned a role that you're not necessarily used to performing. All right. So it is hard. I will admit that simulation is hard because I can't bring the nurses in, right? And I can't get a million actors to come and play all these random nurses and techs and pharmacists that come to codes. So I appreciate that. And I think it's really good. And I think it's good to keep that in mind that this is not 100% reality, but challenge yourself to treat it as much as you can like reality. And if you feel uncomfortable being a team leader, try and step up to that role. Sound good? All right.
But really, to shock this guy, you have to call for code blue because you will not be able to pull the code card without calling for code blue. So this is really can be a code blue patient. So if you have somebody that you need to shock them, give them competence, you need to call for code blue.
Good. All right. So the next case is a code blue. All right. So when you guys show up, we're going to treat it like a code blue. So Helen and I will go and get it set up, and then you guys can come whatever speed you want to the code blue for the patient. That was maybe not a medicine patient to begin with. All right. So anybody have anything else about AFib management, questions of that?
I think we should have independently review the EKG and the reading. Because
Okay.
I feel like in the beginning we misread it because one person.
Yeah.
We read it and we just took it on and this is why the something happened.
Yep. It's very easy to do that where you can anchor on one thing, right? Like, and even if he saw SVT on the monitor and you look at the EKG, maybe you glance at it and you're like, yeah, sure, I would buy that. It's fast with fast AFib to differentiate if it's irregular or regular, right? So that's one of the things you guys have to be aware of. And then I think I assume that you could ask for an EKG. It just is going to take a minute to happen. If you were on the floor and saw this patient, you're just going to have them hooked up to the monitor in the room, right? And you don't have a cart at the bedside, so you'd have to call like a code blue. So maybe I should have made you guys call a code blue to get the pads in there. But
unless you're in the ICU, then you can defibrillate without code blue.
Okay, there we go. If you're in the ICU, you don't need to call a code blue.
Just
All right.
so I know from a technology standpoint,
Yeah.
do we have the ability to actually simulate an AFib with RVR on the actual monitor itself? It looked more like a test.
So that was AFib. That was what it was. Yeah, it's just so fast, I think. Yes, ma'am.
I'll add like how you would manage this, I feel like it's good to get feedback on how you would handle this. Not everyone would go through the order, so.
Yeah. So the debate of diltiazem versus metoprolol, I feel like, is an age-old debate. And so for me in the ER, if this patient came in, either diltiazem or metoprolol, when do you not want to use metoprolol, or when do you not want to use diltiazem? Cardiomyopathy, heart failure. Yeah, so basically I won't do it if there's congestive heart failure. The ER data says that DILT is better in the short term, so I usually reach for DILT personally. But they have like same outcomes at 90 minutes, which is what you guys care about, right? So usually if I call cardiology, cardiology tells me to do metoprolol. So I think choosing one that you're comfortable with, knowing when to give one and when not to give one is important. And then doing that, and if the patient doesn't become hypotensive, you can try a second dose if you need to. How much diltiazem did you guys order?
We went with 10 milligrams.
10 of metoprolol. And what would you have done if it was diltiazem? Do you guys know your dosing for those? There's lots of mumbling. Dilt dose, anybody? $25, $20, it's 0.25 mg per kg dosing. So I usually do 20 as my initial dose. It comes in 10 milligram vials. So usually I do not do 5s because my nurses have to draw up half. And then as soon as the patient becomes unstable, yes. If you walk into a room and you're worried about a patient, I'd encourage you to like get the pads on them quickly. In the ER, if this patient came in as like a medical resuscitation, we would put the pads on right away. But it sounds like on the floor, this would probably be like a rapid response. Is that what you guys call them here, rapid response, right? Okay. So it'd be like a rapid response first, probably, and then as he started to tank and become unstable, then you would do like a code blue to get the cart to you, right?
One suggestion, if you are not sure if it's AFib or SVT and your patient is stable and you have a chance to do EKG, do the EKG on 50 speed. So this will slow your rate into half. So you can tell if it's regular or irregular. So you can switch your 25 to 50 on the EKG machine. This will slow everything for you. You can tell if it is regular or irregular.
And then if you give adenosine to AFib, what happens? It slows down and you see that it's AFib, right? So it won't hurt you if you do adenosine first. All right, are we ready to move on to the next case?
One last thing.
Yeah.
Whoever is in the room, please try to speak louder because we couldn't hear very well.
Okay.
I hope so. The monitor doesn't show much.
Yeah. I don't think so.
Okay, listen, so we have here the code coming. So the next group, get ready.
All right, code blue, room 25. Code blue, room 25. Think that's well enough?
One of them went to the list.
Hey man, I didn't have a pulse. I don't know what's going on.
No pulse,
Need
two
some
pulse,
help.
No
no
pulse.
pulse, continue compression. I'll take a report. Take compression, sir. You have IV access?
We have one IV in the right.
Can we check IV access is working,
I'll
please?
take care of the SS.
Thank you.
Solver, do you want to get the?
Yes, I'll be the team leader, okay?
Are you
Thank
ready?
you, everyone.
Working?
What happened, sir? Can you please?
So this patient was just admitted for like osteo. I came into the room, we found him laying on the ground. I don't know what happened. He was here because he has an infection in his foot. Yeah.
Did you check his monitor, please?
No, monitor.
Do you have
Want us to
anything?
get him on the monitor?
Yep.
Pausing from your breath.
Can you push compression now?
Yeah.
Thank you. Push the
Know when you're ready.
Alright. 4, 3, 2, 1, correct. Check pulse.
You have no pulse.
Okay.
Is it on the monitor now?
Yep. Can we check the monitor? There you go.
You have to go to the. That is accurate.
Can we check the monitor, please?
That's correct.
The monitor is there.
That's right.
Okay, check pulse.
You have no pulse.
No, but continue compression, please. Do you have the IV axis working?
Yep, your IV axis is working.
Can you prepare 1 milligram of adrenaline, I'm sorry.
So,
1 milligram of adrenaline.
okay, I'll pull up the milligram of epinephrine.
Okay,
When do you want me to give it?
I will tell you.
All right.
When we switch compression, let me know when you're ready. Thank you. We switch compression.
How long have you guys
Can we
been
give that
doing
to-
compression? How long?
2 minutes, 2 minutes.
1 milligram
How
of
do you know?
epinephrine and IV.
Stop
Maybe
recording
time?
a few times?
Yeah, I need to take the time.
Yeah, okay.
Thank you.
Also document it.
You have
You have 2 minutes of compression.
30. Can we go to advanced airway?
Yeah.
Yeah, it's okay.
You can.
That's it, thank you, lady. Thank you.
Did we give the epinephrine? Yeah, I already gave it, yeah.
2 minutes past.
Verify. No, it's not. We're like 3 minutes in.
Okay, this patient came with osteomyelitis and then he arrested suddenly. We are just checking what really causing that. So we check the 4H and 4Ts. No, so hypogenia before this.
No,
No hypoxia, there's not any oxygen.
he does not have any oxygen.
No hypothermia.
No, temperature was normal today.
Okay, any change in needs, electrolytes, potassium was low or high?
No, it was all normal this morning on his lab.
Any, we suspect any tamponading or infection in the thorax?
I don't know, do you expect that?
Can we get an echo and check the cellular?
4,
3, 2, 1, 2.
You
Check
can,
pulse,
you can check.
check monitor,
No pulse.
Swimmer pulse.
okay, kidney compression.
Okay, it's been 4 minutes since we started compression.
Yep. When was last time we get epinephrine? Okay, can you prepare 1 milligram of epinephrine for the next switch, please? Thank you. Can we check ABG and RAPS for them?
We can do an ABG if you have a potassium of 6.8, or sorry, a pH of 6.8 on his ABG, and then labs are PET.
Okay, can we prepare these sodium copies?
Yeah.
15 minutes?
Sure. Oh, it's okay.
You can get,
Okay, I'm gonna go ahead and get 50 milligrams sodium bicarbonate to the IV.
thank you.
Push. It's been 5 minutes since starting compression.
Okay. Again, I listen to his lungs.
Yeah, bilateral movement, no concern for tension.
Concentration. What do you think is maybe going on? We have checked it. Oh, yeah, she's all. What kind of medication this patient is?
He's on lisinopril, Aspirin, metformin, and he's doing daptomycin for his infection.
Does it mean no allergies?
No allergies.
Is it medication running right now?
No, he got it this morning.
It's fine, okay. They need medications right now.
No,
Look at his skin and signs.
Been 6 minutes since.
Okay, so do we check, can you give the epinephrine?
Yep.
Please?
Using
Can you check pulse? Check pulse, please.
People.
no pulse.
Check the monitor.
1 milligram of epinephrine and the right AV.
Yeah, no. How many rounds left do you have again?
272.
Do we have the left side yet?
No, labs haven't come back yet. You can do a bedside ultrasound at next pulse check, you're able to find me down hallway. So no pulse is present, you do a bedside ultrasound and you see no cardiac activity.
No tamponade, okay.
No tamponade,
Okay, yeah, continue.
no cardiac activity.
Continue compression, please. Okay, well, can you prepare 1 milligram of epinephrine, please, for the next stretch? What do you think guys want to be using? Any ideas? To check the port, the H's, NPs, and it doesn't have any history of drug intake, no history of toxin intake, no.
No, really administer anything other than epinephrine.
No, what do you think?
You
What
the
should
biomarker,
be?
right?
Yeah.
You didn't give it a
Yeah.
Sure, so you're talking to me.
I mean, we don't have the labs yet, and we doesn't have any history of hyperkalemia, any renal disease.
So he's here for infection.
So like, nothing we can reverse right now. We give the sodium by 12, which is which we have. No, he's got a test. For no release, no.
I think he's doing it.
We can run through.
You can run fluid, there's nothing on his legs on his exam. Then another 2 minutes since your last pulse check.
Can we check pulse?
You do not have a pulse.
Check marker, please. No, of course, marker was compression, please. Could you give the patient active, the patient walk out? Yep.
Oh, go ahead.
The patient is pulsed up, but he is 89 years old.
What's contact sampling?
What do you guys think about going on a wall like this? 89 years old.
All right,
Yeah,
2
that's-
minutes since your last pulse check.
How many
So in total, we've had
cycles did you do? You have it done?
We've done 3 rounds of epinephrine.
How many?
No pulse.
No pulse. How many cycles did you do? in general?
12, so 6 rounds.
We'll continue to 10 rounds, guys, 20 minutes, and then
All right,
No,
fast
that's a
forward,
pulse.
you've done 10 rounds.
it's okay. Can we check pulse? Check
No.
monitor?
No pulse.
Okay,
That's your monitor.
not aggressive course for now. We have been doing this for 10 cycles, 20 minutes. I don't think we are done. We check, just double check pulse and we're done.
All right, so time of death. Time keeper. So now.
Now, it's 20 AM.
All right, we can go back over to Don't worry.
Thank you.
He died. Double check. I think
Did you call?
All right, guys, how did it go? All right, did everybody know what the diagnosis was? Do we have to review what they did, what the case was? You guys could hear okay-ish? So it started out as PEA, right? Because he had actually had something on the monitor, but we didn't have a pulse every time we checked. So they did epi, they gave bicarb, and then after multiple rounds, right? Towards the end, he went into asystole, and then we called the code, right? So how did that feel? What do you guys think you did well?
Yeah, and he was loud enough.
Okay, assigned roles and was loud enough, so you guys know kind of your goal over there for volume. All right. That's it, that's the only thing they did?
They went through the causes.
They did H's and T's, yeah? timer and documentation. We got there eventually. We got there eventually. Yep. Closed loop communication. I thought you guys did a good job. So you did roles very early, but not quite all the roles, right? We talked about your timekeeper is key and they are often forgotten. And
I have one for the line and two for compression
Mhm.
and one for the monitor, one for airway. So we don't have one for time.
okay, if I had 3 people in a code with me, I would make one be my timekeeper. Yeah. So it is that important. Otherwise, you're just like, you're just standing there doing compressions, which is exhausting, right? Sorry, you guys did a great job. A+ for compressions. But so if you don't have a timekeeper, you don't know what you're doing in terms of when to check a pulse. It is very hard unless you want to take that role on as a team leader. But as the team leader, you should try and offload as much mental thinking as you possibly can. So you had a card in your hand, which was awesome. That is perfect because now you don't have to think about when do I give epi? How much epi do I give? When am I going to check for whatever next? So that is offloading mental capacity. The other thing I like to do is if I'm running a code, I will turn to whoever my medication person is and I will say to them, I want you to give epinephrine every other pulse check. Tell me when you need to know, like if we do it. And then I'll tell my timekeeper, I want you to keep time and I want to know when we have 10 minutes or 10 minutes, ew, 10 seconds until our next pulse check. Because that gets everybody in the room ready to go for your pulse check, right? Because you're standing there and you're like doing chest compression. And you're like, oh my God, how much longer? Do you guys work out and have to like hold things? If someone can count me down for 10 seconds, it is so much more manageable than me just like wondering how much longer it's going to be. And everybody in the room knows that someone's got to get their hand on a pulse, right? You got to check. The one thing I will say in terms of like medical management and stuff, when you are checking pulses in a code, do not feel for radial pulses, especially if you have a PEA patient, right? So go for carotid or femoral to do pulse checks whenever you're in a code. You can do that as the team leader. You can do that as the medication person. Don't take your hands off the airway if you're that person. But if you have someone else like at the head of the bed, make sure someone's getting a finger on the carotid. It can also help you feel if you're getting good chest compressions, right? So you should be able to feel femoral or carotid pulses when someone's doing good chest compressions during a code. All right. What do you guys think that they could have improved upon? So we talked a little bit about timer early. Anything else? Yep, and the pulse checks. Yeah, I think that is really key, like asking questions. If you feel like you're stuck as the team leader, like what you were saying, I'm sorry, don't your name, but what she was saying was, you know, don't be afraid to make yourself a little bit vulnerable, right? Everybody's goal is to take care of the patient. No one cares if you ask, like, what do you guys think we should do next? Everybody in the room is capable of coming up with solutions, right? So you guys did a really good job with going through the H's and T's. That is super important. But then asking, and you got there, but asking the room, does anybody else have any other ideas? Does anybody else have a problem with us calling this at the next pulse check? And I think that's okay to do. All right. Yes.
I have a question. So it's my understanding that the only time that you need to stop chest compressions to do a rhythm analysis is if you have a EEG. But if you are manually monitoring somebody, like if we are monitoring that and we're not using an EEG, we can still be touching the patient. So we should still be doing CPR. There will be artifacts, but we should be able to, like, we're good enough at reading them more the better than the machine. You know what I'm saying?
So I don't know what it looks like on the floor, but the pads and the monitor that we use in the ER, you cannot be doing chest compressions to check a rhythm because you're doing your chest compressions on the chest and it moves all the electricity around. It makes it bounce around. So you do have to pause. Same on the floor. Okay.
You'll see a lot of compression. You may even feel pulse with the compression. Will not be accurate. The only one thing that you mentioned too is to encourage using technology.
Yes, that's the other thing. So trying to get your patient on end tidal, I had those numbers for that patient, so I could have given you those. So get your patient on capnography. I feel like I sometimes take for granted how much everybody else in the room does without me telling them to do it. And so it can be a little awkward in these simulations to be like, to remember like, oh, I want and title as well, right? Because the nurse probably put it on for you already, or RT probably put it on for you, but that's good to think about and look at. And then the other thing is minimizing chest compression breaks. And so 10 seconds or less is your goal for pulse check. So that's why you want a little bit of a warning leading into your pulse check, because then whoever's not on the chest can put their fingers on where the pulse is. It'll help you as well if you can feel the person's compressions giving you a pulse, because you know you're in the right spot. In the ER, sometimes we'll do the ultrasound for our pulse checks because you can get a good view of your artery and you can see if there is a pulse or not. And so that's good. And then when you pause, anybody feel a pulse? No pulses, resume chest compressions. Like that should be your sentence. Like no like commas or periods during your sentence. Like, does anybody feel a pulse? Pause, resume chest compressions. All right. All right. And then I like to prep the team that we're going to stop CPR and that we're going to call it. And so you can say, like, at the next pulse check, if we don't have cardiac activity, we don't have a pulse, we don't have a rhythm that's shockable on the monitor, we're going to stop. That gives people time to process and everybody knows. And then there's none of this like, oh, am I supposed to keep doing chest compressions, or did you want me to do something else? It kind of prepares everybody in the room that we're going to be done after this. Questions?
Do we need to talk to family in between? I mean, if we're seeing there's no response, do we need to update someone about the patient?
So I think that's different for you guys than for us. A lot of times these people come in coding and we don't do that many rounds. Like if they've been down for a long time, I think we had a code last night. We did one round in the ER. We don't talk to anybody. We just tell them afterwards. But I don't know what the protocol is on the floor for you guys. Like, I mean, if you can have someone and there's enough people around, you can be like, call family right now, tell them that he's coding. That's great. But it kind of depends on how long you guys want to run it, right? Too, it's like, if you're going to run it for 30 minutes, you probably have time to find someone's phone number and call them. At the same time, are you going to have meaningful outcomes after running a code for 30 minutes? Who's to say, right? So it sounds like no protocol for you guys. We don't really have a protocol. If family's there, I do like to bring them in the room. I know that visitors are just starting to come back in the hospital. Hopefully they're around, but if not, you can always call.
Especially if it is unexpected on the floor, most likely the people on the floor are not really very sick.
Yeah.
Maybe a reason to prepare the family that something's going on. Again, and Sabir, don't worry about personnel. You have more than enough personnel. You did the role of the RT and the pharmacy and the nurses, and you will find at 3 minutes the pharmacy shouting, it is 3 minutes, get every, the nurse was documenting, will tell you it is time for every, so everybody will remind you with the every dose, and you have more than enough personnel when you are going into here.
So that is very true the next 2 years. And then wherever you go after that, or I guess there's some med peds, I saw some names and I know some of you are med peds because I've worked with you at Children's too, but wherever you go in the next 2 to 3 years, it might be you. So know what that's going to look like for you wherever you practice in the future, but it's very nice now that you will have all the mind power to help you guys with this, all right? All right, so our asystole PEA, you guys did that just fine. And then H's and T's, we went through that. Is that on the code card still? It used to be, it should be, right? Okay, so you have those on your code card, right? So you should run through those, think about what causes there are. If there's any chance it could be something, you can always intervene in that way. So fluids were discussed, that's good thought, especially if this patient is there for infection, maybe with septic, but he just died, sorry. Yes, ma'am.
Do you continue contractions while doing a
No.
Do you stop? And then
Yes, so that's a good question. So I would not do compressions when I had a giant needle, but I would be doing it ultrasound guided if I was doing it. I don't know. I've only seen one patient where I like carried a needle in my back pocket for the rest of my shift because I thought she was going to code on me, but I admittedly have never done it. So I probably would not do chest compressions because you're probably going to stab someone. I don't know if this answers that question, but when we have traumas and when we do like the thoracotomy in the ER, we stop chest compressions for that. And it's like prolonged, no chest compressions, but in theory, you're fixing the problem. I don't know, Dr. Gohar, have you done?
I don't think you probably will need to stop compression while you're doing, but probably the most experienced one who did it, if you have some cardiology or surgery around. Sometimes when they open the chest, they pump them.
Yeah, we do.
Manually.
Yeah, we do manual like compressions if we do a thoracotomy in the ER. Longest code I run, oh, we don't run it very long. All right. All right, group 3. Are we ready? All right. Helen, are you ready? Am I doing okay on time?
Let's do it.
Hey, can I get some help in here? I'm kind of worried. I don't think I feel a pulse on this guy anymore.
Third compression, please. Can you feel the pulse? Okay.
No pulse.
Okay. No breathing. Okay. Third compression. Okay. Lower airway. Okay. Blood pressure. Okay. You have the cardiac instrumentation. We have the meds.
Sure.
Can we have 2 IV access, please?
Yes, I'm on IVs.
Yeah. Blood monitor, please.
Yeah.
Can we have history of observation?
I just got called into the room. He said he all of a sudden felt like his heart was racing and then he was unresponsive. I felt for a pulse and I didn't feel anything. And that was right when he walked in.
Okay. Continue compression. Okay. We get 2 IV access, right? Okay. Timer is here. Documenting everything, please. So what's history of the patient? What's the condition?
So this guy got admitted yesterday for an NSTEMI. He's been just waiting for cardiology to take him to the cath lab. He's been fine until today. And all of a sudden, I got time.
Okay.
There, 50 seconds.
Okay, good. So IV access, get left, please. So this patient was waiting for heart cath, likely maybe he has like a cardiac arrest, MI, okay, continuous compression, getting labs done.
Labs are
Okay,
on.
how many minutes now?
For 110.
Okay, continue compression. We're gonna check. Okay, the monitor is, okay. It's feedback, we're gonna check after 2 minutes. Okay. So we're gonna stop after 2 minutes, check pulse, okay? So just, you
30
know.
seconds.
Okay,
I'll get everybody just in case.
yeah.
Okay.
15
15 seconds.
We gotta be ready to check pulse after 15 seconds, please.
Your access.
Yeah, we have access.
5 seconds.
Okay,
Pulse check.
so compression, pulse check, monitor,
No pulse.
no pulse, what about rhythm? Okay, beta, continue, chest compression, we gonna give, AP,
Would you like pads? Would you like your pads are in the patient? Oh, we got pads. So would you want to do?
no, shock, yeah, just shocking,
Everybody clear?
shock,
Charge. Oh, you have to charge.
What do you want to charge to? You're charged to 120. You can do
Okay,
one shot at 120,
stop.
clear.
Everybody clear?
clear,
And then shot, push the red button.
Shot delivered.
Okay, continue chest compression. Okay, we have one to speed that. We're gonna give Ibi, 1 milligram Ibi, please.
I got it. 1 milligram have you given?
Okay, good. We have to look for reversible causes, 5H and 5Ps. What do you think, guys? Can we get a part for the patient? Looking for pneumothorax, with other views and anything?
You don't see anything. We have the,
Yeah. Okay, so we are thinking about ACS now, and we're gonna consider giving a TBA to the patient. Any thoughts?
We should try to shock it.
Yeah, okay. Continuous compression. How many times now?
We have 1 more minute, 1:15.
Okay. We gotta give every other cycle.
1 minute.
Okay. So just, we don't have to like focus on one problem. We don't have like tamponade, we don't have a pneumothorax. That's subject yet. Looking for toxins. Okay, what about timing?
So 35 seconds.
Okay.
Twenty seconds.
So we can check pulse after 20 seconds, please.
Okay, pause CPR. Pulse check.
Pulse check, monitor.
VTAC,
Beta.
shock.
Okay, Chuck.
Every clear.
Clear.
Alright, talk.
Okay, good. Continue chest compression. Can we alternate the chest compression after this cycle, okay? So we give it, yeah, we can give every other cycle. So next cycle, please, let us know to give other every, okay? So to summarize, we have 2 shocks for the patient. We give 1 EP. Next cycle, we'll give another EP.
30 seconds.
Gonna check pulse after 30 seconds. And the rhythm check. This will be the third. Let us know. Thank you.
15 seconds. 5 seconds. Pause CPR.
Pulse check.
No pulse.
No pulse still. Vital. Okay. Continuous compression. Shock. Yeah. Okay. Continuous compression.
Would you like to get another dose?
Yes.
Yeah. 1 milligram of AB now. Can we prepare amio?
1 milligram have you given?
Can we prepare amio 300?
We can.
Okay. Now we have 3 shots, right?
3 shots.
Okay. Can
2
we give
doses enough now.
amiodarone 300 milligram IV?
NEN?
Okay. 300. Okay. Okay. Just compression. Now we have 3 shots. Okay. We give amio. We give
2 doses
AB. Okay. 2 doses AB. So I think now we have to consider TBA for the patient. Okay. Any thoughts? We can like, okay. We can like call cardiology quickly for TBA.
Okay, 15 seconds.
Okay, we're gonna check pulse after 15 seconds and check rhythm. Can we prepare TBA as well, please?
5 seconds. Stop compression.
Okay, check pulse, rhythm.
No pulse.
We have a pulse.
We have a pulse.
We have a pulse.
Okay, we have a pulse now. Okay. Okay, so
So now we need
now
somebody to.
Rosca is achieved now. Okay, can we keep the airway? Okay, can we for the ICU pillow, for the cardiology pillow? Okay, get EVG, chest X-ray.
Everyone's on the way after that.
Okay. Okay, we have intratracheal intubation. Okay, we can check vitals again. EKG have checked. Okay.
All right, good job. I'm gonna go back.
Good, yeah, good.
Thank you, thank you, thank you, thank you.
All right, how do you guys think it went? Good, better, worse? All right, so I read this book called How to Decide by a former professional poker player named Annie Duke. And her very first chapter is all about basically reasoning. And she says that decisions are often decided if it's a good or bad decision based on outcomes. Okay, so just because you guys got the patient back doesn't necessarily mean that you made the right decisions, right? So the example she uses in the book is that you can run a red light and not have a bad outcome, right? But that doesn't mean it was a good decision. Or you can go through a green light and get in a car accident. That doesn't mean it was a bad decision. So I think it's something that we take for granted in medicine a lot. I'm not saying you guys did a bad job. I'm just saying that just because a code doesn't go as you want it to, doesn't mean that it's a bad code. So remember that when you're on the floor, you can still have someone that unfortunately doesn't make it, but it can still be a well-run code. All right. So what do you guys think they did well? Everything. Okay. Well, that is some high compliment.
They assigned the role.
Assigned roles.
The leader was very active. And, apart from that, the only thing that was kind of missing was attaching the pads and analysis of the rhythm.
Attaching the pads and what?
Analysis of the
Analysis of the rhythm. Yeah.
and could be the medication. I am not sure about the medication. That after which time we should have the
Okay.
medication of the medication.
Yeah.
But apart from that, well,
Okay. Anybody else have anything?
I like the rest of the patient.
Good.
He asked for suggestions.
Yep. Asked for suggestions, reviewed everything as he went through.
People were thinking ahead.
Yeah. In terms of medical management,
I also like how Food, I not only checked in with his timekeeper, but also had the funniest line at the end.
oh yeah, what did he say?
He's like, oh, let's think about the H's and P's.
I love it.
That's my terrible impression.
So the one thing I will say, you do not charge before you know what the rhythm is. So it's a slippery slope. So I get that you guys kind of knew what was going on already, but in real life, when you have a patient that's coding, you do not charge until you know it's a shockable rhythm. And then if you don't get them back, do you guys know what your joules were set to? And how much was that? Perfect. So you guys increase like you should. And then do you guys know have you guys seen where it's been like really successful where you like pause chest compression shock and then resume? So you guys did okay with that. It wasn't terrible. But yeah, so it should be pulse check. If you, so I'm sorry, I don't know your name in the like red, orange, burnt scrubs there. But so if you're not doing compressions when you're standing down, you can put your hand on like the femoral pulse too. So you can have people checking pulses in everywhere, right? So you can have both carotids and both femoral pulses if you want. So you can have multiple people checking for pulses because you might not feel it or might not be in the right spot. And so you pause and say, you did a good job of like 10 seconds. So usually what we say in the ER is like pulse check. We don't say like pause compressions. It just pulse check because everybody knows what that means, right? Like it's a common language, which is one of the things with TMARC is the like shared mental model. So when you say pulse check, everybody knows what that means. It means get your finger on where the pulse is, see if there's a pulse. If you don't have a pulse, you look at the monitor. So as the team leader, you should be expecting, because you're expecting close loop communication, that like, I do not feel a pulse is being said. So you can be spending that time looking at the monitor and not looking at the people that are checking for pulses, right? So you have 10 seconds to look at and analyze a rhythm on a monitor in a chaotic room, and then decide what you're going to do with that, right? So as soon as you're like, okay, no pulses, chest compressions, and then you're like, I saw VFib, I want to charge, and then you charge, and then once it's ready to go, you pause by saying everybody clear, and then you shock and you resume chest compressions regardless, unless the patient starts yelling at you that you're pushing on their chest. Okay, but I think overall you guys did a good job. I realize that is like, you know, yeah, 100%. So, i.e. last group, I expect you to be perfect, no pressure, right? All right. Questions at all about management?
So I have a question about charging the defibrillator. So my understanding is for the first rhythm check, we don't pre-charge, we just wait until we see the rhythm, and if it's
correct,
shockable, we continue CPR until we charge and then we shock.
Correct.
But for subsequent rhythm checks, my understanding is it's better to pre-charge so that we only stop compression one time, check the pulse, check the rhythm, if it's shockable, shock it, if it's not, continue.
That is not my practice when I run codes. Helene, have you seen that in the ER? Yeah. How much you trust the person that's full of adrenaline at the head of the bed to not push the button?
Yeah. I think the rationale behind that is that every time you stop chest compression,
100%.
your flow drops drastically, and then to build up the flow, you still need like the first few compressions are not effective compressions, that's building up.
Yep.
So that's why you want to pre-charge so that if one interruption.
He may change it from feedback to assistant. So
Yeah, he could. So it's whatever your team that's in the room is most comfortable with. So if that's a practice that you guys are used to and no one's gonna like accidentally shock someone, that's fine. But it's whatever you want to do, I guess, whatever you're most comfortable with in terms of like, do you charge it beforehand and think that you're still gonna be in that rhythm? In this, we are a little bit disadvantaged because once again, not a perfect model, but you can see what the monitor looks like, right? Our chest compressions are not changing what it looks like, but when you're in the room and you're doing it, you will not be able to tell or have any idea what the next rhythm check is gonna look like. Yeah, exactly. Do you guys do that in the ICU? Do you pre-charge if it's?
No, just doesn't take a long time to charge. It's few seconds.
So during the 2 seconds in which the deep charge, do you resume compressions until it's
I
charged?
was after the charge, so it will not come. It's few seconds, will not be too long. And actually, the ICU nurse will be doing that for you. And you will have ICU nurse in the code upstairs. So you'll have ICU nurse or ED nurse come to the code upstairs with you. So you'll have experienced nurses even on the floor. So, and they are very experienced and good.
All right. Last case. You guys ready? I think we're gonna run a little over, but
That's okay.
all right. I think it's better that everyone gets to do it, right?
Mr. Johnson, hello? Mr. Johnson. Guys, I can't get him to wake up. I don't know what's going on. Help.
Oh, do we have a pulse?
No, we don't have a pulse.
Okay, please, can I please start chest compressions now? I want the patient hooked up to a monitor. Who's the nurse? Starting compressions. Start compressions, please. Okay, Islam, please, oh, yeah, will you get an airway?
I can do those. That's-
Because we can get an ID access and then we'll be doing your mask. You take this. Okay.
Okay, IB access in. Do you want to put on the lead? I can put on the lead as well because we're short on people. Someone taking time.
Yeah, just taking time.
What's going on?
Can we connect is he hooked up to the monitor yet?
Yeah.
You don't stop that.
Let's see what rhythm we have.
What is our monitor?
Oh, we actually have to connect them. I'm sorry.
Okay, so, if the witness the arrest, what do we know about the patient?
This patient came in, they were feeling, they had an AKI and got admitted for some fluids. I don't know, I just walked into the room. I don't really know much more about him.
Has anyone listened to their heart or lungs?
I just walked in the room right before you guys.
Okay,
So we know what we're doing.
where is our monitor?
Monitor.
Okay, post compression, substitute. Okay, continue compression, please. Let's check towards the defibrillator, please. Charging.
2 minutes.
120, ready.
All clear.
Okay, all clear.
Clear.
Shot. Deliver shot. Continue compression. How long is it?
2 minutes.
Okay, can we give him 1 milligram of epi, please?
1 milligram epinephrine in.
Okay. Can we go on his labs?
Chest compressions look kind of slow. Are you getting tired?
Yes, no.
Maybe at the next we can switch.
Somebody CDC, GMP, radiation. What was his reaction this morning?
The potassium has been a little bit high the whole time. They really aren't, their kidneys aren't working, so. I don't know exactly what the number was, but that was what the other nurse told me.
And then,
How many minutes?
30 seconds left.
Switch out as next.
So what do we think is happening right now? What do you think is happening right now? Is he an AKI? Is he going overloaded?
So we have a visa arrest. Most likely it could be a combination of his acidosis and then life and
2 minutes. Or pulse check. You still pulsing? No, no pulse. See what's going on. Still weak, but the charge.
Compressions. Charge. Charging. Ready, clear deliver shot. Continue compressions. Charge breathe. Can we give him 300 milligrams of any other role, please? Calcium gluconate, 10 milligrams of calcium gluconate, 4 milligrams of magnesium sulfate,
300 amnio given.
calcium.
Calcium given and magnesium given.
Okay, 1 ankle bicep. 10 milligrams.
Calcium what?
10
10 seconds left. I'm gonna try to get another I don't think so. 5 inches and 5 teeth. We think he might be hyperkalemia, he might have some acid-based stuff going on.
Okay, it's all over the AKI, so my thought process is we can have acidosis, hyperkalemia, low QT, might have blood control then hence the magnesium. I thought okay.
Yeah, we
My
can
bad.
go.
I thought I said blood control. Maybe I didn't. Okay, so 1 antibiotic, thanks for reminding me.
Triforce given. 10 seconds left for the next pulse check. We can have someone call the family. I'll
Okay,
work on that.
in the meantime, can we get an ultrasound?
Yep, we'll get the ultrasound.
Thank you.
Mhm. The pulse check, no pulse on the monitor, still VFib.
Okay, charge, continue compression, charge, defense, please. Charging,
Ready?
charge ready, clear, okay, all good.
Okay.
This is the charge. Charge delivered, continue, compression.
Sitting by for there.
Okay, do we have any of the labs?
No, no labs.
Okay. And is he, do we have entitles here too?
Yeah, and title is set up and it is 10.
Okay. So,
So we can actually do another.
sure. Go for it. What do you guys think? Yeah, sure.
Okay, then 1 milligram epi.
Okay. Next cycle will be, maybe in a second.
And the hands left. Oh, yeah, we have.
Then be ready to push with the nine, we'll start. Okay.
So what's the patient's blood pressure?
Yeah.
No blood pressure.
We don't have a pulse.
No
Oh,
pulse.
okay, charge. Continue compression, continue compression. Charge. Like in the- thank you.
With his sorry. I mean.
Shock ready, clear. Deliver. Shock delivered. Continue compressions. We'll give the second dose of amnio. Gatsby, please, 150 milligrams of amnio, IV.
Okay. 150 milligrams. I'm ready. You're doing a great job.
Okay.
Please have some practice. 150 on your given.
We're going to do empirically for hyperkalemia, let's go some insulin defect.
Okay. Give it 10 minutes. Insulin. And give it 10.
You want to? Yeah,
10 seconds.
Okay, can I get ready to take over? The sun looks better. You want to, everyone start today?
How many? Is it 10 seconds?
Okay. Done?
Okay, pulse check. You feel a pulse. Okay.
Oh, we got the
All
pulse.
right, the pulse. So what's the blood pressure? It's like 80 over 40. 80 over 40. Did we get any of the labs back? No. Okay.
Okay, the patient is intubated, right?
Yes.
I'm doing this as if it's a tube.
Yeah,
Okay.
intubated.
Okay, so the patient needs to go to the ICU, put a central wire and OR5, short pressures. And we can give him a shot of phenobarbital now and 500 milliliter bolus until we get to the ultrasound and know what his food status and how his heart is doing.
Sounds good.
All right. How do you guys think they did? Were they perfect as a group 4? I told them in the hallway already they weren't, so they know. So what do you guys think went well?
Team leader
Their role. Team leader enthusiasm, good. Good, they minimize interruptions and compressions. They reviewed
got
everything,
labs.
what could be causing it. Yep, they got labs.
Consider magnesium, magnesium.
Yep, okay. What could have gone better?
Go with the algorithm, like check the H's and T's, even if you have a reason, maybe other reason causing that. I don't know if they have done the.
They kind of discussed it. They didn't go like top to bottom, but they thought about it. Yep. So check the H's and T's. Check the rhythm sooner. Okay, so not closed loop communication, open loop communication. Okay. Maybe not a loop at all. Okay. How did you guys feel in the room? Did you feel like it was organized or did you feel like it was a bit chaotic? Everyone felt like they knew their role. I feel like you guys did a really good job assigning roles early and you were very clear about who was going to do what. And I thought you did a good job of, you know, like doing medications, but it wasn't necessarily like coming from the team leader. Sometimes it felt like you went a little rogue on your meds, but like, oh, I'm going to get some more amio now. And so closed loop communication. Oh, okay, bye. Oh. I don't know. I don't know. But okay.
No compression. I'm done.
So real quick on like medical management of that patient. So a few things. Yes, if you have a patient that I should have probably had this guy on the monitor when you walked in. But if you walk in and you see someone in BFib that's not responding, you do not wait 2 minutes to shock them. Early defibrillation is one of the 2 things that you can do in ACLS to make a difference in someone's survival. Do you guys know what the other thing is that you can do to make a difference in someone's survival? Chest compressions, yeah. So good chest compressions, early defibrillation. In a patient that you suspect hyperkalemia, they gave calcium. Did anybody hear what calcium they gave and what dose they gave? What calcium did you guys give? Calcium gluconate. Is that the right answer? They're dead. You can't make them more dead. Okay, so calcium chloride in codes, always. And what is the dose of calcium chloride that you give in a code? 10 what? How much, Helen? 2 amps. So the amps are how calcium chloride is dosed. Okay, so you want to know that. You guys gave sodium bicarb. How do you dose sodium bicarb? Amps, right? But yes, how much is an amp? Yeah, so how much do you get? An amp, maybe more. There's no evidence to show that sodium bicarb, calcium, magnesium, unless it's surface, have any difference in outcomes of patients. So they're dead, so you can do it. But if you don't do it, it's not wrong. But if you see like someone come in and you are worried about hyperkalemia, calcium, and then give more calcium, and then give some more calcium. Like you can do amp after amp after amp. The insulin in D50 is not going to be as helpful because what does the calcium do? Stabilizes the heart, right? The insulin and the D50 are just a shift. And that was the one other thing I wanted to mention that you guys didn't do that we, I think in the ER do a lot, is finger stick glucose on all of these patients when they're unresponsive for you. I think it's less likely on the floor, but 100% every rapid response you go to, you should walk in the room and say, what is their sugar? Anything else for that case? Dr. Gohar, anything else for that?
Yeah, the 1 half of calcium chloride has 3 times what you have in the 1 half of calcium glucose. Okay, so this is very important. 30 versus 10. So calcium chloride is what you use on the code. You can give repeatedly, especially if you're thinking hypertension. Magnesium may have a role in you have to start or something like that. So compression was ineffective at sometimes with the last code. So if you see somebody who is not doing efficient compression, maybe start, just try to switch. So
Oh, yeah.
make sure the compression is.
Thank you for bringing that up. I was going to say, you do not have to wait until the 2-minute mark to switch compressors. If you have someone who is tired, it is way more important to pause and get someone that can do good compressions than it is to have the tired person make it to the 2-minute mark. Have any of you guys done compressions in a code, an actual code? It's exhausting. Okay, like I don't consider myself that out of shape, but 2 minutes of compression is exhausting. And so do not be afraid if you are starting to get tired to ask someone to switch you out too. So you have to be your own advocate as well. Don't wait for your team leader to recognize that you're tired. Like you guys were getting tired in the back. Just ask to be like, hey, can someone switch me out? I need a break.
And that would they tire out earlier on.
So the last case I changed because you said you guys didn't like when they were supposed to be there, but we're going to do bradycardia. So real quick, what do you do if the patient is bradycardic? Number 1, blood pressure. So stable or unstable. If they're stable, atropine, how much? 0.5 to 1. Okay. And if they are unstable, PACE, call cardiology, ASAP. All right. So take home points. Team communication. You guys, I think, very quickly realized today how important team communication is, being a leader, assigning roles. These are all what actually matter in ACLS. It is not the algorithm, which for the longest time, when I was a resident, I was scared of the algorithm, but it turns out I can just be bossy, and so it's fine. But know your algorithms, or at least know where to find them quickly so that you can offload that mental work onto a card or someone else, or get help. Defibrillation saves lives. So early defibrillation, if you see someone in VTAC, walk in the room, call a code, shock that patient immediately. And then high quality CPR. So if you see someone that is not doing good chest compressions, do not be afraid to kindly correct them or offer to switch them out to do chest compressions. All right. I have, because I'm an education fellow, I have a little QR code for feedback. If you guys liked the lecture, didn't like the lecture, I cannot see who gives the feedback. If you have time, that's great. I know we went over, I apologize, but I really, really, really appreciate your enthusiastic participation, because this is very painful when people don't answer the questions or do the simulations. All right. If you guys have any questions, I'm usually in the ER. Or you can email me. Dr. Gohar has all my information, so feel free to email questions. Otherwise, I will see you guys in the ER or at Children's. Yeah. All right. I don't do.
Tomorrow we'll be here too, exactly at 12. We'll start with the electrolyte imbalance. Be sure here you are here. Bring your stethoscope tomorrow with you. And bring umbrella to straight.
Bring your umbrella. Right. Yeah. I'm gonna stop sharing, but
I know you are not here tomorrow.
Thank you. Yeah. Sorry. Thank you. I promise I'd rather be here.